Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh.
Is there pus coming out of the insertion site? Your patient will code. Kind of like anyone that has ever played bingo.
You can transplant the heart, but you can't transplant the brain.
I velcroed myself to the respiratory therapist when I was a baby nurse. Ejection fraction. I was like, oh my god, I hit an artery.
What's up, guys? Welcome to the Fresh RN podcast. I am Katie Cleaver.
And I'm Melissa Stafford.
Thank you for joining us today. We have a wonderful guest here, Sean Dent. What's up? We want to jump back into CRRT. So what does CRRT stand for?
Continuous renal replacement, and that is basically another form of dialysis treatment for a patient who is either in acute on chronic or acute renal failure, someone who needs dialyzed. And CRRT is a much gentler insult to the body than HD being hemodialysis. Hemodialysis is usually anywhere from 2 to 6 hours, and it's over the fluid removal versus hemofiltration, and it can be a little taxing to the body's hemodynamic system. So after 2 to 4 hours, 6 hours of hemodialysis, and they remove 2 kilograms of fluid, you can imagine that if someone who is already having low blood pressure problems is going to have even worse low blood pressure problems. So in someone's infinite wisdom, they decided to start continuous renal replacement. And so instead of a 2 to 6 hour treatment at a large volume and large rate, it's over a 24-hour period, and it's at a trickle rate. So it's a lot more tolerable for someone who has unstable hemodynamic parameters. The best piece of advice I can give with CRRT is probably to master the machinery that your facility utilizes, because over the years, just in my short time, I've experienced 3 different machines. And each machine comes with their own set of heartaches and troubleshooting. They seem to get better every year. The machine is dependent upon the flow of the catheter. So it goes right back to where's the catheter placed. It's once again a central venous catheter, so it's just like a central line, except it functions a little differently. But for bedside nursing purposes, you're going to treat it and care for it kind of the same way. I believe, if I'm not mistaken, in every facility you have to take some sort of training class in order to be able to use CRT or to take care of a patient who is on CRT, because there's specific criteria and things that you got to watch for and monitor and pay attention to.
It's very specific.
Not only from the machine perspective, but the catheter perspective. And it has everything to do with troubleshooting. So if it's not working, knowing what to do to help augment the treatment. You want to treat the catheter the same way you treat a central line, the same way you treat an A line. You're looking for patency. You're looking for infection. Is it actually sutured into place? Is it moving? Is it not moving? Is there pus coming out of the insertion site?
Is the dressing intact?
Yes, is the dressing intact? So the best piece of advice is to make sure you master the machine on that one.
So hemodialysis, is the catheter the same?
No. So you cannot do you cannot do CRRT through a AV fistula, which is what most people have. Okay, I take that back. There are different types of accesses for a patient on chronic dialysis. Chronic dialysis can be a fistula, or they can have what's called a permacath. And a permacath usually is placed in the chest wall, but I've seen them in the femoral. Very rarely have I seen it anywhere besides the chest wall these days because of infection rates. And a permacath, if I'm not mistaken, I don't think you can do CRT with that either, because it has to do with the flow. So the short explanation for that would be blood flow is going to go in one direction through one catheter, and when the dialysis nurse accesses an AV fistula, they use 2 catheters, one for venous, one for arterial. That's why it's called a fistula. But when you use a CRRT catheter, it's actually kind of mimics what an AV fistula looks like. It's going to have two separate ports. One's going to be inflow, one's going to be outflow. But there's no arterial and venous. The catheter sits in the vein. So there's no access to the patient's arterial system. So there's a washout just in the venous system with inflow and outflow.
So, like, okay, let's say I've got a patient, because working in the neuro ICU, I never did CRT. I never took the class. It was the ICU nurses that did that. But if you have a patient that maybe they were on hemodialysis, short-term hemodialysis, and then they say, oh, well, we got to start CRT because that they're not handling that or whatever. Can you use the same catheter for that short-term?
No.
Okay.
Yeah,
okay.
So CRT,
they need a new one placed.
Correct. They need either a temporary dialysis catheter or they're going to need a more permanent dialysis catheter. Either way, the catheters, and I could be wrong, the catheters used for chronic dialysis are not the catheters you can use for CRT.
Okay. And
it's all about whether or not it has access to the arterial system, is what it sounds like.
Yes.
Okay. Yeah, CRT is no joke. You have to have a specific class, and I would think as a new grad you have to work for a certain amount of time before you can even take a class like that.
You need to get comfortable with stabilizing hemodynamics. You got to be comfortable with drips, vasopressors. You got to be comfortable with somebody that most of the time is on the ventilator.
Yeah, because this is a sick pup that needs this.
Yeah, they are very sick. Most of the time CRT is for someone who needs dialyzed, who is hemodynamically unstable.
Yeah, so that's a big kind of deal.
Yeah, and then you go into the specifics of the CRRT treatment, but from a bedside nursing perspective about the equipment, you treat it the same way.
Yeah, and I know I've never run one of those machines, but I always hear the nurses that have talk about it's the most annoying alarms, and it's very finicky.
Because it's very flow dependent. So
and
any
it's a
change,
trickle.
So any change in
so
any change in the flow rate, if there's any changes in the flow rate from outside to inside the patient. So is there a change in flow rate from the machine? So is there something going on with the machine or the filter? Or is there something going on with the catheter itself? Because the catheters are very, what we call positional. So the catheters, high flow rates are going in and out of a single, here I am wanting you to look at my fingers through the podcasting microphone. I don't know how to describe other than you have a single catheter that has two lumens of equal size on both sides that have two separate ports. One is going to be inflow, one is going to be outflow, and they're going at a high pressure rate. So pushing fluid in and pulling fluid and blood out at the same time, and sometimes those high flow rates and high pressures can cause the catheter to bounce up against the actual vein, the vessel.
Sense.
So what we call it's sucking against the wall of the vessel. So sometimes that happens, and then you have to troubleshoot the machine until you've exhausted your efforts. And then the staff nurses usually have to approach the provider to see if they can manipulate the catheter itself, maybe twist it or pull it back a little bit because one of the ports could be sucking up against the vessel.
Ooh.
Yeah.
Sounds like a problem.
Yeah. So it's just dysfunction of CRT. It doesn't harm the patient.
Oh, okay.
Yeah, so it's not harming the patient. It's just that the CRT is not working.
Okay. Do you have any other CRT questions? That was pretty good.
CRTE. I don't think so.
Okay. So let's move on to impellas and intra-aortic balloon pumps. Are those the same thing?
No, they are not. From a management of equipment, I would say okay, they are. Meaning that they both are catheters that are inserted into the groin. One is on the right, one is on the left.
Which one's which?
So usually the balloon pump is on the left and the impella is on the right.
Wait, are you saying that people typically have both of these at the same time?
No.
Oh, okay.
So you can have one or
okay.
the other. Now I think about it, I've had two patients that have been on both.
Okay.
It's a rare case.
No.
Okay. That's usually a very, very, very sick puppy.
Okay.
So the most common one is the IABP, the intra-aortic balloon pump, and it is an augmentation device to offset afterload. And for those of you that are familiar with ICU nursing and hemodynamic parameters, you have preload, afterload, and contractility. Afterload has to do with the systemic vascular resistance of the body, which equates to your systolic blood pressure. And that is a very generalized explanation. And all that is doing is giving the heart an extra kick. So afterload is, what is the heart pumping against?
The resistance.
The resistance, systemic vascular resistance. The IABP is going to pump, or it's going to inflate at the end of diastole. And without going into an entire lecture on hemodynamics, what that is doing is it's allowing the heart to work a little less. So it's giving the heart time to rest.
So most often after surgery, these are placed?
Most often.
Or a cardiac event?
Cardiac event. Let's go with a cardiac event,
Okay.
because it could be from an MI, it could be from a bypass surgery, it could be from a valvular surgery if someone has like an aortic valve replacement. There's all kinds of things that would be the cause for it, but ultimately it has to do with giving the heart time to rest.
Okay.
And it's, of course, a temporary device. The other device is the Impella device, and that is what's called a ventricular assistive device, not an LVAD. It's basically a device to help with the strength of the EF of a patient. EF being the ejection fraction.
Yeah, I always say EF, but then...
Man, that just went right over my head. Wow.
You just had a little bit of expressive aphasia.
Man, I'm glad you saw that in my eyes there. So,
Expressive.
and the best way I can describe it is when someone has a cardiac event and they have what's called a cardiac stunning. Basically, it's kind of like getting knocked out, but the heart got knocked out. It needs a little bit of time to wake up. So the Impella device helps the heart wake up without having to work in overtime. And it does the same thing as an IABP. It just does it in a different part of the cardiac cycle with a different part of the hemodynamic support. Both catheters are treated the same way from an external perspective. You're looking at treatment of, once again, a central line. So you're looking at infection, you're looking at the ports, you're looking at bleeding. Is there irritation? Dressing changes. But then the devices themselves have troubleshooting things that you're going to have to learn to address. Impella pumps and IABPs work on timing mechanisms, and they work on how often do they inflate or deflate in the cardiac cycle. Every time that you have a between systole and diastole, how many times is the balloon pump inflating? And they use a ratio of 1 to 1, 1 to 2, 1 to 3, 1 to 4. And depending on your patient's profile and what's going on clinically, will determine the amount of support the patient needs. And as a bedside nurse, you do not need to get bogged down on that particular aspect of the machine. You just need to understand how the patient reacts to it, meaning that if your patient all of a sudden becomes more unstable, then they need either more or less support. And that's something that you need to communicate with your provider, with your doc, with your advanced practice provider, your NP, your PA, or your cardiologist, if that happens to be, how things work in your facility.
So 2 things come to mind with that. Just to clarify, are both of these catheters in the venous system or the arterial system?
Venous.
Venous. And are these patients being anticoagulated while they're in place?
That is up for discrimination. So it all depends on the process. So you need to clarify that every single time that catheter is in. Because it could be for a heart attack, or it could be for a post-cardiac surgery. And anticoagulation is treated differently for both of those. So, yeah, I would not assume one or the other. I would clarify that from day one. Don't ever assume just because they have the pump in that they're going to be anticoagulated in 24 hours, 48 hours, or they're going to be on Plavix and aspirin on day one, because each surgeon, each cardiologist, each interventionalist treats it a little bit differently because of the patient's comorbidities and their disease process. For instance, someone who has a coagulopathy, who has unstable bleeding pattern, you're not going to anticoagulate them. Even though they should be, for one reason or another, you're not going to anticoagulate them. So while the guidelines are going to tell you to anticoagulate under certain conditions, it's patient-specific.
Are patients that have these awake?
They can be. They can be.
What kind of, if the patient's awake and not, vented and sedated, what kind of considerations do you have to have?
They're going to have to lay flat. Most of the time they can't sit up because of the catheter where it is in the groin. You can't, there's not a lot of evidence that support it, but it's just kind of a traditional practice that this is one of those catheters you don't want to mess around with, because if it's not flowing properly and then all of a sudden it's not working, you can have a cardiac arrest. So usually just best practices, they're allowed to sit up, I think, maybe 20 degrees, maybe 30 degrees if you're lucky. But many facilities that I've worked in, both as an NP and a bedside nurse, they usually leave them flat because these are temporary devices.
Very short term.
Yeah. The longest I've seen them in is probably 4 days.
Okay.
4 days is the longest, and that was because the patient was unstable.
Okay.
But it's a very temporary device, and if after 4 days they're still not tolerating what's going on, they're probably going to need an additional intervention of some sort.
Okay.
And that could ultimately be surgery again, for one reason or another.
Is there a complication related to the catheters just by having them in place? I mean, I imagine probably one of the biggest concerns is they're not working properly as far as allowing the heart to rest or providing better circulation. But is there a complication from the catheters just being there?
Yeah, catheters just being there can cause bleeding, hematomas. You can have things that are called pseudoaneurysms. I'll let you go ahead and Google that one. All that basically means that there's a hematoma forming inside the body somewhere where there shouldn't be. And that can cause compromise in circulation to a limb or to an organ. So it's something that will have to be addressed, and it could be a dislodging of a catheter. So if the patient is agitated, take for instance a patient who's intubated but not properly sedated, who's sitting up and agitated and pulling at things. Just imagine if they sat up and they accidentally dislodged the catheter in some way, whether it be an IABP or an Impella, that can cause profound hemodynamic compromise. So, and there's usually no fix for that at the bedside. They're taken emergently to the cath lab. So, yeah.
Are these removed at the bedside?
They can be.
Is that not ideal?
No. I've seen both. Okay. So it all depends, once again, on the patient profile. But that is something that the surgeon interventionalists will remove. I take that back. There are some advanced practice providers that are specially trained that they can take them out. The biggest concern once you take the catheter out is that you can have post-removal hypotension and bradycardia. So, and that's something that nurses who care for these patients on a regular basis get trained on. You actually take classes for. It's kind of like when you take a CRRT class. You're going to take a couple classes on these catheters and how to manage them.
Okay. Do you have any more questions on those?
I could make this episode quite long by asking questions because it's fascinating.
Yeah, because we don't deal with these. I'm like,
I could still go back and talk about CRT some more, probably.
Yeah. Oh yeah.
Yeah. I think
we'll move forward. I guess so. Well, let me go to this next one. Internal pacing.
Yeah, so you can have temporary pacemakers. So you can have internal pacing for someone who has a electrophysiology compromise. So someone who is refractory bradycardic, or someone who has sustained VTAC. You're going to need a temporary pacer. You're going to need a temporary pacer to stabilize them until they can get a more permanent pacemaker. And that's also inserted through the groin, and it's also very positional, so the patient cannot sit up. They have to lay flat or maybe 10 degrees, because once again, if you compromise that catheter and the wires aren't doing the job it needs to do, your patient will code.
Yeah.
So
is that like an instant code kind of thing?
Yeah.
I didn't want to say
it usually starts out as, well, that looks, wait, what? Oh crap. That's kind of what happens, So, especially if someone's in complete heart block, And complete heart block is a disassociation between your atrium and your ventricles, that they're not communicating appropriately, so you're not perfusing blood appropriately. So basically, you have no perfusion, and you can have a complete cardiac arrest. You can have a PEA, cardiac arrest, like that. So you have to have some sort of sustainable underlying rhythm. So you externally pace them with the pads on the front and the back, and then you take them to the cath lab, and then they have an emergent temporary venous pacemaker placed. And it is monitored and managed by the doc or the interventionalists, and it's also troubleshooted by bedside nurses. Once again, another class that someone will take, because there are two settings on the pacemaker that you can be in charge of, because you can actually take a verbal order over the phone and tell the cardiologist, hey doc, for some reason I'm getting intermittent capturing of the V-pace, so I'm getting a low bradycardic, my blood pressure's going down. So then the doc will say, well, go ahead and turn the MA up to 60 or turn the MA up to 70. And I'm not going to bog you down with what MA is and rate and control, but it has to do with how much joltage do you need to give before there's actually a capture, that what you're giving the patient is actually working inside the heart.
It's causing the electrical activity.
Yeah. Okay. So everyone has taken care of patients who have pacemakers, and you have what you consider 100% capture versus 50% capture, is that you see a pacemaker spike, but there's no actual correlation to a change in their PQRST. So it's kind of the same concept, but once again, the catheter is just temporary. And those are always usually done in emergent situations, or you need to stabilize the patient before you put in a permanent pacemaker. For instance, the one that can come to mind is that someone has a bloodstream infection. You're not going to place a permanent pacemaker into someone who has a bloodstream infection, because that is just a place to seed. And you definitely don't want the pacemaker itself or the lead wires to seed an infection, because then it goes right to the heart. And need we talk about bacteremia inside the heart valves?
Yeah, we don't need that.
So badness all around. So yeah. So someone who has hemodynamic instability needs to be put on a pacemaker, they will put a temporary pacemaker in. Now, there are options sometimes with position that you can leave them, instead of being completely supine, you can have them at 30 degrees and sometimes 45 degrees, but it really has to do with the amount of support on the pacemaker that the patient needs. So this is, once again, a very specialized piece of equipment that nobody is going to expect you to care for a patient who has a temporary pacemaker in if you've had no training on it.
And typically, I would think, more so than the other, like the Impella and stuff, that a patient on with this pacing, they're more likely to be awake.
Yeah, oh yeah, absolutely.
Okay.
Yeah, they can absolutely. They'll be conversive. They do not feel the pacing.
It's not like they're getting
it's not like a defibrillator, you know. So it's pacemaker. It's pacing them. It's not defibrillating them.
Okay.
So
they can have epicardial wires too after like a big
open heart surgery, so it's a little different.
Oh, I know how to use those. I got a story for you guys. Okay. So on the cardiac step down, we had that all the time. They always had pacing wires, because you leave them in for a certain amount of time just in case you need to pace afterwards. So they literally wires out of their chest. It's really creepy looking. They all have abdominal binders, because they have that sternal incision. So where I worked, we had like these look like syringes, like empty syringes, to kind of cap them, and normally we'd kind of stick them in the binder to keep them together and right there. And I was getting a patient out of bed, and he, I thought they were all in there, and they were not. And we were in a recliner chair, and I stood him up, and I heard boop, and he was like, "Oh, I don't know what that was. It just felt like a tug." And I was like, "Huh, I don't know what that was." So I sit him back. It was like a turn and pivot situation. So I, put him in bed, and then I'm like, I see the empty syringe on the floor and the pacing wire on the floor, and I'm like, sweet Jesus.
Are you
I
sure?
run out to the front nurse's station like, oh my God, what did I just do? And this patient had actually, because those are left in on everybody after like an open heart or a CABG, just in case, right?
Usually.
And then, so this person had flipped, they had to actually use it in the ICU a few times. And the physician was like, I'm going to leave them in longer because this guy, we needed them more than other patients. And I pulled it out early.
Oops. Did you have the pleasure of calling the doctor and telling him that?
Oh, he was on
Or
the
her?
unit.
Oh, nice.
Yeah. He was like, I thought I was going to get reamed.
Mm-hmm.
But I think the way I approached it, like, oh my God, I can't believe this.
You feel bad for it?
I think he was like, I think he felt bad for me because he could tell, like, it was totally unintentional. And he was like, well, I guess we'll see what happens. I'll keep the pacemaker by his bed or whatever. Or I don't remember what he said.
You just have to, I had a patient, I floated over to the CV ICU one day. And, okay, I'm a neuro ICU nurse. I'm not a CV ICU nurse. Yeah. And they give me this patient who's completely awake and alert, and he's just chilling in the chair. And to look at him, he was. They didn't tell me the part that he still has pacer wires in. I'm like, I don't know what to do with this. Like, I know that there's capture and sensitivity and all that kind of stuff, but there's a lot of charting and stuff you have to do with that. And I don't know. No, guys, sorry. No, I can't. No.
But, it's a good take-home point is that if you're a new nurse and you get exposed to something like that, you need to speak up immediately so that someone can either familiarize you with it or maybe rearrange the assignment. Don't
advocate for yourself.
Yeah, don't ever put yourself in a situation where you're compromising patients' safety. Sure, there's a level of comfort that you're never going to have, but if it's something that you can be educated on at the bedside and you have support, you absolutely can take care of someone who has pacer wires that are sticking out post-operatively. Everybody can take care of them. It's just knowing what they are and what not to do to them, like pulling them out, like pulling them out, and knowing what they're used for. So, being able to recognize that your patient's going into complete heart block, or they're having frequent PVCs, or they're having some sort of cardiac instability, that maybe the provider needs to hook them back up to the pacer, and that's why those pacers are there. So, yeah, don't ever feel afraid to speak up to someone. That doesn't mean that you're going to get out of taking care of the patient. That just means that you're going to have to be educated on how to care for that piece of equipment.
Yeah, I think it's important to learn it at some point and
Absolutely.
don't constantly avoid it.
If you're in a unit and you've got a lot of strong nurses around you that can keep an eye on you, that's one thing.
Right.
Than being, in a unit full of new graduates or people who have less than a year experience with only one experienced RN.
And you've got like the how-to manual, like.
Yeah, you're reading it at the bedside. So yes, absolutely. So that definitely compromises patient safety.
All right, so let's move into our last little section of proning devices. What is proning? What are some devices? When are we going to run into this? And I know you can use devices and not. So let's talk
Which
proning.
we learned today.
Which I learned today.
Yes. Proning is exactly what it sounds like it is that instead of someone laying on their back, which is called supine.
You must know your positions.
Yes. You are going to lay them on their stomach. And this is in extreme respiratory failure scenarios. I think everybody, at least at some point during their basic nursing education, heard of the term ARDS, ARDS. That's acute respiratory distress syndrome, adult respiratory distress syndrome. Don't we love our acronyms?
Yes.
And what that basically means is significant and severe respiratory failure. And some have called it leaky lung syndrome. It has everything to do with capillary membrane leaking. Your lungs can't hold on to the water they need to hold on to, and things leak into places that they shouldn't. Everybody has probably maybe at least heard about the ground glass appearance of chest x-rays. That's ARDS. So prone therapy came about 12 to 15 years ago, maybe 15 max. And it was theorized, and it has been proven since then, that if you take a patient from laying on their back to laying on their stomach, It's kind of like anyone that has ever played bingo.
I love bingo.
Okay, so if you ever played bingo, and there's that, what do they call that with the balls, the bingo balls in there?
I don't know.
I don't know what they call that, where they pull the bingo ball out of that crate that they're spinning. Anyway, the short version is that if you're laying on your back, your lung tissue that is closest to your chest wall, closest to your nipples, is receiving the most oxygenation, or is open the most. Mm-hmm. And that if you are, so whatever is closest to your back is dependent. So you're only oxygenating your lungs partially. So the anterior portion is oxygenating, the posterior portion is not, because of that leaky lung syndrome that we're talking about. Fluid always travels down. Mm-hmm, mm-hmm. So what if I were to take you and just turn you upside down and flip you, so now your stomach is laying on the bed and your back is toward the sky. So now whatever is anterior is going to get oxygen, and whatever is posterior is going to have the fluid. So basically it's just a concept of trying to allow other parts of your lungs to be well oxygenated. There's a lot of other anatomy, physiology, that we could go into. That is the basic of basic versions. So you can imagine that someone who needs to be proned is a sick puppy, mm-hmm. and they are on a ventilator. That's not an option because they're that sick. They're usually on a ventilator. So there's a mechanical ventilator attached to the patient who has an endotracheal tube in their mouth, and now I'm going to throw them on their stomach. Just by pure common sense, you can imagine how difficult that can be. Because now where's their face going to go, and the gear that's in front of their face, and the tube, and the circuitry, and all of those things. They have created over the years a specialty bed, and I don't know if it's a proprietary, copyrighted thing, but the traditional bed is called the rotoprone bed, ROTOPRONE, rotoprone bed.
It looks like a monster.
Mm-hmm. And basically it sandwiches the patient from top to bottom, and it spins on its axis, so that you put the patient in the bed, you lie them on their back, and then you clamshell them from top to bottom. You secure their head, you secure their feet and everything in the middle. You strap them down, and we have joked, turn them into a burrito. You basically turn them into a burrito, and you spin them on their longitudinal axis so that you can go from their back to their stomach without having to compromise any of the equipment that happens to be attached to the patient. And it's a very coordinated movement that the best way to research this is just to actually go Google rotoprone.
Yeah, take a
and
look.
There are tons of videos, pictures that can give you at least a better visual on what I'm describing. And it is a way, so the evidence that's out there says that proning someone is beneficial in ARDS. The evidence is out there that it confirms that proning someone early is effective. What evidence doesn't support is the manner in which you leave them there. So I put someone on their stomach. Now it's pretty much guesswork as to how long do we leave them there. Do we do what's called kinetic therapy, which means do I kind of lean them on their right side, then lean them on their left side, then lay them flat on their stomach? There's no evidence that supports or refutes what's better and what's worse. So everyone has their own kind of method. At the end of the day, putting someone on their stomach is beneficial. If you do not have a bed, you can, I guess the best term I'd use is jerry-rig. Mm-hmm. You could jerry-rig a set of pillows to put on their chest and above their head and on the sides of their head, and you basically manually just flip them from their back to their stomach with a lot of support, of course, from your fellow.
A one nurse
no. That it usually takes a good 10 people, because you're going to have to stabilize all of the equipment that the patient is hooked up to. So you're going to need at least one person at the head of the bed holding on to the ET tube, another person holding on to the feet. You're going to have one or two people on each arm, one or two people at the hip, one or two people at the legs, so that one person on one side of the bed is turning, and then there's an equal person on the opposite side of the bed receiving the patient as you flip them on their stomach. So you can imagine it as a very coordinated dance, mm-hmm. And you have to prepare for pressure ulcers, and that's what the concept of the bed does. is it tries to relieve the pressure ulcers that can be acquired from laying on your stomach, because we as human beings are probably you are built to lay on your back.
Mm-hmm.
Not for an extended period of time, but you're built to lay on your back. If you lay on your stomach and put your face on the ground, how long can you lay there before you have a sore or something starts to hurt?
And you're dead weight. You're
Yes.
not like
Right.
like if you go lay on the bed on your stomach right now, and you can pick your head up and move around and
Correct.
But these patients are dead weight. So
Yeah.
you think about that much weight.
Yeah.
Yeah, that's a lot of.
So nursing 101, decubitus ulcers,
Mhm.
you know, so
Your pressure points change when
pressure
you're prone.
points change the minute you put them on the stomach, so you have to try and relieve those pressure points. If you don't have the rotoprone bed, you're going to have to anticipate what are the pressure points when you lay them on your stomach. You have to worry about the forehead, the chin. You have to worry about the cheeks and the shoulders and the sternum and the chest. You have to worry about your ASISs on your hips. You have to worry about the groin area for men. If someone has abdominal girth, you're going to have to worry about that.
Mm-hmm.
Someone is obese, you're going to have to worry about that. You're going to have to worry about the knees and the ankles and the feet and everything in between. And then you're going to have to anticipate all the tubes and the lines and the IVs and the Foley and the NG and the central lines and the A lines and all that stuff is going to have to go somewhere and not compromise your patient's skin.
Yeah, because rarely is it the patient attached to only a ventilator. They're attached to
Yep. There's
17 IV pumps.
Correct.
And a central line and probably a feeding tube or whatever.
So once again, this is a very advanced technique that you would not be responsible for as a new nurse. In fact, the first time that I think I took care of a patient as a bedside nurse with a rotoprone, I think I had 4 years of experience before I got trained on that. So yeah, you need a lot of support with that.
So what kind of goes with that is the oscillator.
So I don't have a lot of experience with the oscillator, and the oscillator is kind of, I think, in my own personal and professional experience, I think it's just for the babies. It's for the babies.
We
Do you guys use it
for adults, but most of the time that I have seen it, we're on adult patients that have the flu, and they were not ventilating well in the traditional mechanical ventilation, and they tried bi-level ventilation, and that failed, so then they try the oscillator. I have also seen it used as kind of, and I don't really know why because I don't know anything about ECMO, but I have also seen them try and do that to get somebody to oxygenate better until they can get them transferred to a facility that does ECMO. But the sound of a patient on an oscillator is crazy. It is so loud in that room, and the respiratory rate is so high.
Do you remember how high it is?
I want to say the last room I walked into, I want to say it was in the 50s, like 55, I think. A respiratory rate, but the tidal volume is incredibly low. But they're sedated and they are paralyzed because they cannot fight against that oscillator at all. They cannot be. They cannot be in any way, shape, or form offering any sort of resistance to the oscillator. But I have never cared for it myself. It's fascinating to me.
No,
and look at equipment,
I've worked at many facilities, and I mean we've done proning. Proning is actually quite common in the higher level facilities, but I think proning is superior to oscillating, and I think oscillating is probably expensive, is my guess.
I would assume
guess.
So yeah, that machine was crazy looking. It's a 1-to-1 patient, and I just looked it up, and it says the high frequency oscillation ventilation differs from conventional ventilation in that very small breaths are delivered at a very rapid, meaning 180 to anywhere from 180 to 900 breaths per minute.
Oh, see, look, I totally made that up. I thought it was 50 something.
It helps with the opening of collapsed lung tissue by providing constant positive pressure in a person's airway. Which
is what you can do with just about any setting on a traditional ventilator. So, I can't say that there's a lot of evidence that supports oscillators these days. When's the last time you saw an oscillator?
I saw one.
It's usually during flu season that I see them.
Yeah.
But I honestly don't. And it's not my unit that does it, so I wouldn't necessarily know. But I don't remember if they have.
I think there's a lot of exclusion criteria, meaning that if someone is obese or if someone has any kind of trauma of any kind. I don't know.
The rate of barotrauma
Well,
This man
yeah.
breathe 180 times a minute.
And it's like a last ditch.
Yeah, it's pretty much
This-
salvage therapy.
Right. Like if we're doing this.
I think it has to, if you have that ability, but you can't get someone to a facility to do ECMO, I think that's pretty much what you have left.
That's the last time that I remember seeing it was on a patient that they were basically trying to buy time to get him to another facility to do that.
And prone therapy used to be the last ditch effort, but now we're a lot more aggressive with it because we've become more comfortable with it as a medical society. 10 years ago, prone therapy was like it was like everybody's eyes got 3 times larger. Like, you want to do what? And now it rolls off the tongue like, we're gonna have to prone this patient, and everyone's like, okay,
Yeah.
let me know when.
And earlier.
Yes,
better.
yeah. Within the first 48 hours, you'll see the most success, and it's really cool to see a patient who, pretty much would have died had they not been flipped on their stomach. And
That's crazy.
And it's
That's
usually
crazy.
very immediate. Usually within hours, you're gonna see
the
this
neuronurse wants
ridiculous.
to know what happens to ICP when you're pregnant.
Yeah, you're right. Yeah, I can't say that not
I
anything
know.
recently. No, but we've done it where it was, we could have a conversation about heart versus brain again and lung versus brain.
Oh,
but
wait, I've got to wait, quick before you move on with that. I remember, so someone tweeted this to me.
Mhm.
Heard a cardiovascular surgeon and a neurosurgeon talking about what's more important, the heart or the brain. And the neurosurgeon said, you can transplant the heart, but you can't transplant the brain.
You're right.
Mic drop.
Yep, yeah, mic drop right there.
Sorry, but okay, go ahead.
But at the end of the day, if you're not oxygenating the heart or the brain,
You're not your
that
brain.
trumps everything.
Right.
So you could keep the brain all you want, but if you're not actually oxygenating the tissue, it really won't matter. So I think at the end of the day, if your patient's that sick and it's a choice between stopping ICPs and putting them prone, I'm pretty sure most providers are going to say prone them.
Yeah, I just
You're going to
can't.
have to, and just
Take
deal
that
with
risk.
the
If they're not
consequences.
I mean, to your point, if they're non-oxygenating, their brain
It won't matter.
Right.
Right.
It won't matter. Oxygen wins every time.
Yeah, I would think that would be truly, in that situation, a last-ditch effort.
So out of curiosity, as an advanced practice provider, what is your favorite device, maybe, that you get to use?
Or where you get report on a patient, you're getting, hand off, and you're like, ooh, we've got this today.
As an APP, I'm probably going to say ventilators, because when I was a bedside nurse, they scared the bejesus out of me, and I made it my goal in life to master them. I wanted to be comfortable with them. I think we might have had a conversation either on podcast or outside that, I Velcroed myself to the respiratory therapist when I was a baby nurse, and I had them walk me through everything. And then as I got more seasoned as a bedside nurse, I became more and more comfortable with the more advanced settings. So when people would talk about bilevel, I knew exactly what they were talking about and what the settings were. And then when I became an APP and we were moving on to the more advanced therapies, I Velcroed myself to my intensivist. Anytime they stood in front of a ventilator, what are you doing? Why are you doing that? What'd you touch? What are you doing? And now I am extremely comfortable when someone is crumping and they need advanced ventilator techniques. I don't get scared anymore, and I don't break out in a cold sweat. I of course will immediately call my physician colleagues, but when they're crashing and I need something immediate and they're not there, I'm comfortable enough in my skills at this point that I can do just about everything I need to do, short of having a surgeon at the bedside, to try and help them and resuscitate them. And it's a good feeling sometimes when you do certain interventions and the physician comes in and goes, "Yep, that's what I done." So,
that would feel
That's always a good
awesome.
feeling.
Yeah.
So and I mean, at this stage in my career, I'm not the doer, I'm the teacher now, which is kind of nice. So, yeah, I like ventilators because they scared me so much.
So take home is, if there's something that scares you a lot, don't shy away from it.
That's
Jump into it and become
Fear
the master.
101, man. I'm sorry, but like if you're afraid of heights, what do they tell you to do? Introduce yourself to a little bit more and a little bit more and a little bit more until it's no longer scary. And it's the same thing with everything you do as a nurse. I can remember giving my first subcutaneous injection on an orange. And I remember having bullets of sweat because I was like, what if I screw this up?
Yeah.
You know, that poor orange by the time it was over, you know. And then I remember giving my first sub-Q injection to classmates. We injected, you know, a little millimeter of, you know, saline into our shoulders, into our deltoids. And I remember giving my first sub-Q injection to my good friend, and the site bled. And I, like, went pale. I was like, oh, my God, I hit an artery, you know. But you learn, you become comfortable as time goes on, and you got to stay uncomfortable. Anything... You got to get out of your comfort zone in everything you do and master it, because it's the only way you're going to get better. Do you really think that seasoned nurses are comfortable with what they do by accident?
Yeah, or because they avoided it.
Yeah. They take the challenge assignments, you know? Get outside of your comfort zone, man.
All right. Well, any more device questions? Do we miss any? Was there anything you really wanted to say about ICU devices that you did not already say?
Real quickly, I think we skipped over non-invasive cardiac monitors. Just 2 minutes of, you know, instead of using a Swan-Ganz or a PA catheter, which is an invasive device that sits inside the heart, you can actually monitor cardiac output from the outside to in. So you're just using an external device. You have some that you can just put monitor leads on their chest wall, and then you have some monitoring devices that will do calculations by using an arterial line, which is, you know, an A line. And when I started as a baby nurse years and years ago, Swan-Ganz catheters were in everybody. And now we barely use them, and if we use them, we put them in there, we get a set of diagnostic measurements, and we take it right back out, because of the high risks of all the bad things that can happen when a Swan-Ganz is inside your heart. So non-invasive cardiac monitors have everything to do with monitoring fluid volume status, monitoring cardiac output, cardiac index, and cardiac performance. And it's just yet another tool in your toolbox. And it's a really cool monitoring system for the bedside nurse because you manage that entire machine. I place the catheter and I will give you titration parameters, but you're in charge of the machine. So it's actually a pretty darn good feeling as a bedside nurse. You have a high level of independence with that machine. So
Interesting. Cool.
Yeah.
All right. All right, guys. We'll check out the show notes at freshrn.com/podcast. I will try to find non-copyrighted pictures of these devices, but I'm not making any promises because that might not be super easy. But I think, you know, just even Googling them, just so you can see what they look like instead of like a drawn picture in your book. And something also, too, if you know you want to work ICU and you're in nursing school, highly recommend you know, checking out these devices, even if it's like a patient that's not yours, but someone's on a ventilator, someone has an arterial line, go look at it and try and get your mind around it as much as you can. Having that kind of exposure is really, really helpful. So thank you guys for listening, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat.